and I am excited to touch base with you on some amazing work that has been ongoing throughout the course of the year. We are going to be recording this webinar, and so I ask that you type in your questions into the webinar screen, and we will address those as we go through. And that way we'll keep everybody on mute for the betterment of folks who might want to watch the taped version of this later. Thank you for spending your afternoon with us, at least your lunch hour. We're going to be talking today about the Senate Bill 5557, or pharmacist provider status efforts in Washington State. And really, this is an updated presentation of some of the work that we've done over the course of the summer. The legislation passed earlier this year, and there's been a number of moving parts that we want to update you all on, and then we have some very exciting work to be done over the course of the next year, and so we want to introduce you to that and get all of our expertise and resources in alignment so that we can build wonderful tools. So as you may or may not be aware, obviously this has been an ongoing effort. The provider status effort has been something that's been ongoing throughout the nation, and we're seeing a tremendously exciting time with some progress being made that clearly it's taken years to develop. And so in referencing The Tipping Point, which is a Malcolm Gladwell book about how little things can make a big difference, I felt that there's a couple applicable quotes that you'll see throughout this presentation. But really looking back at all that work and then what makes big change happen, there's the quote that the tipping point is the magic moment when an idea, trend, or social behavior crosses a threshold, tips, and spreads like wildfire. And what you're seeing is a number of folks, stakeholders, lawmakers, really understanding the way pharmacists are trained and how we can be better used in our healthcare system. And that has been due to a number of efforts over the course of decades finally coming together. And so it's my honor to be a part of this, and I'm happy to share with you what we've learned and what our next steps are. As you may or may not be aware, that essentially provider status, or that term, incorporates three components. And the idea is that pharmacists are considered medical providers and paid for their services, not just the medications that they dispense. And that is a three-tiered approach, or a three-legged stool, if you will. There's the provider designation component, there's a scope of practice component, and then there's recognition by payers. And in the state of Washington, we've encompassed this designation component and addressed it over the years, and our latest amendment in 2013 to the Legend Drug Act helped to make sure that we've incorporated pharmacists in all appropriate practitioner healthcare definition. Our scope of practice was worked upon way back in 1979 when a bunch of very innovative and forward-thinking leaders in our state helped to redefine our Practice Act, and that's RCW 1864-11, which I'm hopeful many of you are familiar with. It includes not only the dispensing and safe processing and compounding of medication, it also includes a couple of key areas that are unique throughout the country, and that's the initiating and modifying of drug therapy through written protocols or guidelines. We typically refer to that as collaborative drug therapy agreements, or CDTAs. The administering of drugs and devices, monitoring of drug therapy and use. And so, not to belabor the point, but quickly, WAC 246-863-100 defines the components that must be in a collaborative drug therapy agreement. And I certainly hope you are all familiar, but you can review this. The component that also is a little, at least in discussions I've had, not clearly understood by folks outside the profession, and maybe some on the inside, is the definition of WAC 246-863-110, which is the monitoring of drug therapy and use, which allows pharmacists to collect and review patient drug use histories, measure routine patient vital signs, and also order and evaluate the results of lab tests. And so those components are all within our scope of practice in the state of Washington, along with the collaborative drug therapy agreements. The component that we didn't have of the three prior to Senate Bill 5557 was recognition by payers. Prior to that, we were limited to pharmacy contracts with PBMs, which is not a pharmacist contracting for services, but a pharmacy contracting for professional service provided during the dispensing of a medication, or facility only billing or incident to billing for services in concert with the physician in certain practice settings, and then the individual is specifically identified pharmacist provided services like vaccine administration, MTM, maybe some pilot projects, things like that. But really, these were one-offs and not recognizing pharmacists as a healthcare provider that provides medical services. They were ancillary staff and dispensers of medications, and that's what we wanted to address. Of course, there's always the ability for pharmacists to charge cash for these, but those were limiting our ability to expand our practice further, even though, as you'll hear, we certainly have expanded it to a point that it's made a big difference. So in order to really take a closer look at how we address this recognition by payers, we looked back at current law, and the Every Category Provider Law in 1995 was passed, and that you have references to the RCW and WAC on your screen, but really that's an equity-based law that requires health plans to include access to every category, every type of healthcare provider to provide public services, and in the WAC or rule, it says they shall not exclude any category provider. And it was the basis of this law that we focused our efforts to get recognized by plans. And this is I would be remiss if I didn't mention Don Downing, faculty member, former WSPA staff member, I2P2 Innovative Practice Chair at the University of Washington, and a huge advocate, has spent a number of his waking hours over the past decade trying to get the Insurance Commissioner's Office to truly understand where the pharmacists sit in this particular law. And because initially, Insurance Commissioner Sen's office did recognize that pharmacists could be providers that were under this particular law, but Commissioner Kreidler's office, who is the current commissioner, initially did not believe that that law included pharmacists, and therefore it was not enforced as such. And so over a course of a number of years and a lot of work, we've been successful, and it's a big we, but Don was a very huge part of that, working with the OIC to increase their education around the enforcement of this law. But ultimately, it took the Washington State Joint Select Committee of Health Reform and Implementation, which is essentially a committee made up of the House and Senate healthcare folks in Olympia. Took a joint letter from them, and that was all triggered by Senator Parlett, pharmacist in the state of Washington, out of the Wenatchee area, huge advocate and a big reason why this legislation passed. Back in 2012, she requested and led that effort to get a informal opinion of whether or not pharmacists were included in this every category provider law. That was triggered by Don Downing's efforts with Senator Parlett, and certainly paved the way to where we are today. So back in January of 2003, now Washington State Attorney General Ferguson his office came up with this informal opinion, which in a summary statement, this is a larger opinion, but a summary statement of the opinion was that pharmacists are healthcare providers and must be compensated for services included in the basic health plan that are within the scope of a pharmacist's practice, if the pharmacist agrees to abide by stated standards related to cost containment management and clinically efficacious health services. Really, that statement and the entire informal opinion just reiterated what we had long felt was accurate. The pharmacists were included and should be included within this law, and it should be enforced as such. But that was not a silver bullet, because that was back in January 2013, and through the course of 2013 and 14, changes hadn't been happening, hadn't been enforced, and so we started working more closely with the Insurance Commissioner's Office after this informal opinion to investigate why this law had not been enforced, and ultimately led to the identification of a loophole in the law that allowed health plans to justify not including pharmacists in their provider networks. Essentially, they were pointing to the contracts that pharmacies had with PBMs and the payment for a professional service or dispensing fee to a pharmacist as accomplishing the law and abiding by the law, and so what we did was worked with the OIC to address this loophole, and that ultimately led to Senate Bill 5557 legislative fix. That was introduced in 2015 and passed and signed by the governor on May 11th, and over the course of the summer we've been working hard on it. The legislative intent of 5557 was to fix that loophole that I discussed, ultimately recognizing pharmacists as patient care providers within the scope of the practice that they're trained to provide. It certainly encourages a greater integration and collaboration of pharmacists within healthcare teams, and ultimately we believe it's going to change perceptions of the pharmacy profession and the role we can play in patient care. It also will allow for an increased access to patient care as it integrates into communities throughout our state. We were the first state to actually pass this type of a comprehensive provider status legislation using this approach, and we are certainly hopeful that this tactic can be immediately used by other states with these every category provider type laws. My understanding is there are about 15, 16 of these states that have similar language, and we've been working with our national partners to help them understand our process, and hopefully we can start more of this change throughout the nation. So quickly, Senate Bill 5557 highlights a few key components here. That health plans are required to include an adequate number of pharmacists, and that word adequate is appropriately bolded because that's a key word in network construction, and there's been a lot of concerns about thin networks or narrow networks of providers that don't adequately provide for patient access, and so we'll be continually working to make sure that there are pharmacists in adequate numbers within these networks, but the law actually specifically says adequate. It also includes services that are covered as essential health benefit requirements. The law, originally it said basic health plan, but with the ACA, the Affordable Care Act, that terminology was changed to essential health plan benefits, and there are rules nationally on what a minimal essential health benefit must require, and so that change was necessary, and I think it's going to be beneficial to us in the wellness and prevention areas. It also includes pharmacists in health. It includes a very clear clarification that pharmacies that are within a health plan's drug benefit network do not satisfy these new requirements. That was explicit because of the loophole, and that was to address the non-compliance with the previous law. So in short, summary statement of how this bill really impacts us is that pharmacists will be finally treated the same as other medical providers in the provision of care in the eyes of the plans, and that's the kind of moral to our story today, and we'll reiterate that as we go through. So there's tiered implementation dates, and this ended up being quite significant, I think, as we boil this down. But we've got 2016, January 1 to 2016, so right around the corner. Those pharmacists that work in healthcare facilities that have delegated credentialing agreements, meaning that they have an agreement, the hospital or clinic has an agreement with a health carrier or plan to delegate their credentialing to that hospital or clinic. Those agreements that they do for physicians and nurses and every other healthcare provider, pharmacists will be included in those, and we've been working with a number of our pharmacies that are within the health carriers to discuss the challenges and best practices with which pharmacists are being incorporated into those systems. That's going to lead us with a lot of lessons learned into the second tier of the implementation dates, is that health carriers must accept pharmacists in their participating provider networks. That's all pharmacists independent of setting. I think this is really important because there was a lighter lift with the systems that were already developed for credentialing and privileging pharmacists, and so 2016 was, even though it's quick for us to do it, it was an appropriate time frame so that we wouldn't have to wait several years for this to happen. We could get the ball moving as quickly as possible, and I think you're going to see that a few of the health systems are able to accomplish this and should have pharmacists in their networks for next year. In 2017, we have to build a system that doesn't exist, and that's going to take a little bit longer work, and we'll get into what that is going to entail here soon. So,
Jeff, just going back, there's one question, which is, can you expand a little bit on the definition of essential health benefits and just kind of what you mean by that?
You know what? Sure. There is a fairly extensive definition federally, and I don't have it in front of me, unfortunately. But essential health benefits has been defined within the Affordable Care Act at a federal level, and then the states have been allowed to define it if they choose to in a different capacity. It must include the core components of the federal law, is my understanding. And essentially, it's the base level of services that our legislators in Washington, D.C. decided were fundamental for care. And I think the reason for this is that there were plans out there that didn't cover some of the wellness components, vaccines and tobacco cessation and some chronic disease state prevention components, and because they were afraid that they were going to attract patients that had those disease states. And what the Affordable Care Act tried to do is to make sure that there was better coverage for those prevention and wellness components. And by defining the essential health benefit to include those, it required all plans to have a core number of covered services within every plan that they put on the market. And so that this particular law will align with the work that's being done throughout the country with the Affordable Care Act.
I think notably MTM billing codes don't tend to be a part of that essential health benefit. Similarly, Botox for wrinkles wouldn't be a required health benefit, but yet preventative services around diabetes care, for instance, would be, and some of those sort of services.
Yeah, MTM is not yet incorporated into that component, but immunizations and tobacco cessation and chronic disease state management and a number of the key components, with the diabetes or heart failure, are included in those essential health benefits. And throughout the course of this, we'll make those core components clear, but essentially they'll be what's included in the plans. And there's a number of ways pharmacists are trained to help provide services that are within those core benefits. So thank you for bringing that up, Jenny. I can't see the questions, so I appreciate you chiming in. So there were a few initially, right when the bill was passed, a few misconceptions aired by the public, and so I'd like to specifically some television stations. So I'd like to address a few of those currently. There's the fact that it is not true that patients can just skip their physicians completely and receive all their medical services from pharmacists. Clearly, this is a means with that the pharmacist can work collaboratively with the healthcare team to increase access to care, and that the team approach is still necessary and required. But there may be some services that will fall to the pharmacist because of better access and a more appropriateness of the healthcare provider that's providing that service. It is not true that this particular piece of legislation changed the pharmacist's scope of practice. It did not touch our scope of practice. That actually helped it to pass. It was merely about equity and recognition by the plans. It didn't extend anything we can do. We can still do the same stuff. And in our particular legislative environment, any healthcare bill that it would potentially increase any scope of practice is nearly a no-go. Most of the legislators are not interested in expanding scope of practice, and they really look at it very, very, very closely. Most frown upon any turf efforts unless they're universally approved. And so it was clear. But the good part about that is our scope of practice was very well written back in 1979, and it's allowed us to do amazing things. In fact, there are over 10,000 on the latest numbers that we got from the Pharmacy Quality Assurance Commission. There's approximately 10,000 different collaborative drug therapy agreements on file in our state. About 65% of those are in the immunization realm, but about 35% of those are chronic diseases and other extensions of care which really have not been funded to date. And the immunization component has been reimbursement, whether it's cash paid by a patient or reimbursement by insurance companies, has allowed that to grow, and pharmacists have been a key component in the community with regard to providing increased access to immunizations. But even 35% of these are in areas where pharmacists were not really recognized at all, but clearly have a huge role to play, whether it's in diabetes, pain management, any chronic disease state clinic anticoagulation, or in refill authorization, and a number of components that are integrated into health systems and clinics. There's a number of different ways pharmacists are being used. And this is, I think, bodes well for our future. The statement that health carriers must include all pharmacists within their participating provider networks is false. They, as with any other healthcare provider, get to choose, as long as they're meeting the adequacy requirements, they get to choose what healthcare providers are within their network. And so just because you apply doesn't mean that they're going to take everybody. That's how all healthcare providers work, and so we're going to always be working on making sure that there are appropriate amounts of pharmacists in these clinics, but we're going to be treated the same way as everybody else. That pharmacist provider status will change immediately after the legislation is signed into law. That was also false. Of course, you've seen the timeline of 2016 and 17, and we had some patients that were, once they heard the news, were asking. And then also that health carriers must cover all services provided by pharmacists if they are within their participating provider network, and that's not true. The health carriers are required to cover to pay a pharmacist for any covered service, so it's a service that's already covered within that plan that carrier provides, for a provider if it's within their scope of practice. So a pharmacist has a broad scope of practice, as I mentioned, any covered services that fits, but it's not specifically delineated what are billable opportunities. We didn't want to get into a list just simply creating the yes and no's of what can be billed and what can't, because it varies per setting and how the pharmacist is used in every healthcare team. But the law is very clear that it's all covered services within the scope of practice. So now let's get into kind of the summer work. An advisory committee was created by this legislation, and the OIC designated a lead organization. That lead organization was One Health Port. They formed an advisory committee made up of, I believe, 44 individuals, and over the course of the summer worked to develop best practice recommendations for standards on credentialing, privileging, billing, and payment by pharmacists. Those recommendations were provided to the Insurance Commissioner's Office and Department of Health before December 1st of 2015. I think it was the end of November. And then the legislation allowed for the OIC and DOH to then develop rules based on the recommendations. At current, there doesn't appear to be any rules that have been identified to be changed because, as we had said, pharmacists are going to be included in the current insurance rules that apply to all other providers. But that could change as we identify things down the road. So here's a list of the folks. You can see it's the idea is to be very well represented by multiple groups within this committee structure. We have trade associations, the Medical Association, Hospital Association, of course the Pharmacy Association. The two main health carriers, commercial health carriers in our state, Primera and Regents, the Blues, were at the table. I know that they reached out to a number of other payers as well throughout this process. At least one hospital with an internal credentialing process, and there were a number of hospitals and clinics included. Health facilities with pharmacists providing medical services in the community and in the community pharmacy setting and in the clinics, and we had representatives in those. The School of Pharmacies were represented, and a PBM was offered to be a part of it, and I quite frankly don't know how much the PBM contributed to the process because of the way it was set up, but I know that there was some desire by the health plans to have PBM at the table because they wanted to be able to differentiate between the pharmacy benefit and the medical benefit, as well as potentially looking at the pharmacy benefit manager's role in helping to pay pharmacies for the services, or pharmacists for the services, medical services they provide, which currently doesn't exist, but that they wanted them to be at the table. We certainly have work to do with our pharmacy benefit manager regulation before we feel comfortable with that, because that we've had tremendously poor experiences in recent times. But ultimately that committee worked really with One Health Port to create these documents that I'll be sharing with you. So again, the road started in May with legislation. The advisory committee met with One Health Port over the summer. Deliverables were delivered to the OIC and DOH in December, and now we're in the implementation stage as we look at the first health facilities with credentialing agreements rolling out in 2016, as well as full compliance in 2017, and a number of the implementation work groups that need to be addressed. So this advisory committee work, the intent of it was to ensure that essentially the pharmacist will be regarded as any other healthcare provider in accordance with that state law. That is fundamental to this. As it relates to the healthcare or health plan, medical billing, processing, and payment for medical claims, all encompassed in the idea that there shouldn't be any additional barriers for pharmacists, that if we want to be integrated into a system that might morph and change as healthcare incentives and ACOs and shared compensation models develop in the future, which is still a lot of work to be done, that we're unprivy to the details. We wanted to make sure that we were incorporated in a system that would include us in the future, no matter how that's set. So we wanted to skate to where the puck was going and not where it was. We're looking towards the future, and incorporating pharmacists in this allows for not only a fee-for-service integration, which is currently going on, but to ensure that we're in systems that pay in a capitated or shared savings type of model. The scope of work of this particular committee was to recommend guidelines for payment-dependent interactions between the health plans and the pharmacists or provider organizations, with a specific focus on contracting, credentialing, utilization review, coding, billing, and reimbursement. And so ultimately, with three topics or three documents came out of this. The frequently asked questions document, which is a 13-page document, the largest document. The health plan policy directives document, and the pharmacist and other provider expectations document. So the frequently asked questions document reflects the industry information. So basically, while everybody was asking questions and we were developing what this might look like, there was a discovery process that was underway, and there were needs to clarify and make specific the definitions of terms and the understandings of different things, such as what does 5557 say, clarifications of what law this document was directed at, and then what the scope of that law is. Then we looked at defining, clarifying the pharmacist scope of practice, our licensure requirements, the training and education we get when we receive our degrees, pharmacy degrees, and then any certifications that are postgraduate or identify additional training. There was a big interest by the plans to clearly understand collaborative drug therapy agreements, and so we went into detail on that. One of the biggest components of concerns from the pharmacy stakeholders at the table was that we clearly define what a collaborative drug therapy agreement allows us to do. And so while we identified what the scope of practice was, we clearly delineated there are things within the scope of practice that would be billable service moments that don't require a collaborative drug therapy agreement. The collaborative drug therapy agreement really only allows us to prescribe, which is important in some higher level billing, but shouldn't be required for any billing of any service, because just being able to prescribe does not mean that we're not providing a service. And so we wanted to make sure there was clear differentiation in that, because I think initially there was some plan to say that only pharmacists that would be able to get paid for services were ones that had some prescriptive authority agreement, and we know that that would be short-sighted, and we wanted to make sure that that was clear. Credentialing and privileging definitions, and this whole new language for many of us. Some that have lived in the health system world are very familiar with credentialing and privileging. Others may not call it that, but really do credential. The idea of credentialing is what specific components of your training do you have that shows that you're qualified and competent. So as an example, you're a licensed healthcare provider that received your training from an ACP accredited school or college of pharmacy, that you've passed your NAPLEX and your NPJE, that you've done all your experiential training hours, those types of things. And then privileging is something that's done by the healthcare system. So essentially the clinic or the hospital or the pharmacy that says, because you have these credentials, you can do these things within your practice setting. And so there was a need to define what credentialing and privileging are and how they vary, and who does what within that process. So other questions that were addressed in the frequently asked questions document are pharmacists, primary care providers, or specialty care providers, because that has implications on copay, and clearly there was a focus on, hey, primary care providers, because there's a lower copay, and pharmacists should be incorporated in the primary care component, and not just viewed as specialty care providers. But there was also a semblance of understanding that in certain care settings where a pharmacist is working with the specialist, that they might need to be required or considered a specialty care provider, so that they could, for example, prescribe through collaborative agreement certain drugs that require a specialist or a specialty care provider for coverage, and so things like that. What are the different places of service in which a pharmacist may practice? This is for education to the plans to let them know where pharmacists practice and how that might work. Is a diagnosis required to bill services? This was a big one because pharmacists are, the word diagnosis is a very sensitive, turfy issue by prescribers and physicians really that say we diagnose, pharmacists don't diagnose. So how would a pharmacist be able to diagnose? Well, to bill for a service, you must have a diagnosis code. And so that was clear, but what we identified was solutions, and we'll talk about that. But yes, the diagnosis is required for services. What CPT or HCPCS codes do pharmacists anticipate billing? This was not specific codes, but more general themes of where pharmacists might be providing care and what type of codes should the plans be prepared to see a pharmacist submit a claim. And so that's E&M codes, very much incorporated into probably the main chronic disease state stuff, medication use and immunization type codes, prevention of wellness type codes, things like that. And then how will they be reimbursed? And that's they'll be reimbursed in the same mechanisms that other healthcare providers are. There was a need to clarify what documentation and coding standards are required for medical services, what claim forms are used in the billing of services, and will pharmacists bill directly or as incident to, and clearly we had been billing incident to in many settings. This will allow us to bill directly as well as incident to in some settings where that might be more appropriate. So then the next document was the health plan policy directives, and that really identified any policy requirements or conditions that a health plan would have to have in place to be able to bill and appropriately reimburse pharmacists for services. And we focused in, this particular document focused in areas of contracting, credentialing, utilization management, and coding and billing for reimbursement. And essentially, the summary statement of this is that pharmacists are going to have to be held accountable, or health plans are going to have to hold pharmacists to the same standards that they hold their other healthcare providers and incorporate them in the same way that they do. And then similarly with the provider expectations, which basically lists the expectations requirements that are met by pharmacists and other providers to operationalize within their organizations the reimbursement for their services. The core statement here is that pharmacists are going to have to do the same stuff that other healthcare providers are doing, and we can get into details of that through our work group, but it just more formalized what the processes or how pharmacists were going to be used in utilization management and basically the coding, billing, reimbursement, privileging, credentialing, and contracting components are all similar to other healthcare providers. So the work group, when this was reported, identified 5 key issues. And so I'll just go over those real quickly with you. Does the legislation require all health plans to reimburse pharmacists for medical services that they deliver? We discussed that earlier. That's no. It requires Washington State licensed, insured large group, small group, individual and family plans to reimburse for pharmacist provided services. Those are the health plans that are within the scope of practice of the insurance commissioner. It does not require Medicare. We're working on a Medicare bill, federal TRICARE, Taft-Hartley, or other state plans like public employees, uniform medical plans, and Washington State Medicaid to do this. It also doesn't require commercial self-insured plans to do this. However, when we've gone through this process, Medicaid and public employees and uniform have been at the table. They're very interested in utilizing pharmacists within their provider networks. And so while they're not required, we've been working with them. And commercial self-insured plans likely will have the option of having pharmacists within their teams. And now once this process has has gone forth and their pharmacists are within those networks, we've been under the impression from talking with some folks that likely that will be something that they'll offer to those self-insured plans as a means of trying to gain their contract with them, and so that pharmacists likely down the road will be incorporated into some of those commercial plans as well. What extent, we're not sure. We just know that there's the commercial plans in large and small and family and indemnity that are required. Are pharmacists being regarded as all other health provider types? And the short answer is yes. The intent of this document was exactly that, to pharmacists fall into the every category of provider law and be treated the same way other providers are. Okay, for any given type of provider, say pharmacists, do the credentialing requirements of a health plan vary depending on the services to be provided by that pharmacist, i.e. is credentialing service specific? This was a big question because we clearly have pharmacists working in different settings, and we were concerned that the plans were going to put high levels of requirements to get into networks on all pharmacists inappropriately. And at the end of the day, we were able to work very closely with the plans and with the committee to state that the insurance plans should have a minimum standard based on licensure for getting into their network, and that the credentialing is not service specific, that that should be left up to the privileging and credentialing practices within the healthcare provider system, so the clinics, hospitals, and pharmacies, long-term care facilities where the pharmacist is providing care, that those are the groups that should be deciding what additional credentials or certificates are necessary for the privileging that goes on there, but that should not be in the health plan's purview. I think that was a big deal. So there was some clarification on that. Here's some examples. For health plans, they define a set of credentials gathered and verified for every provider, so PAs, RNPs, pharmacists, and that core set of credentials, as I stated, could be that they graduated, passed their tests, and have done their experiential training and are in good standing licensed provider in our state. That those do not vary based on specific services, that they hold everybody to the same standard, and so that standard should be base level standard. And then for organizations that are both provider organization and a health plan, they provide patient care and take on the financial risk for providing that care, that they may vary based on specific services because they're the organization and the plan, and so then they actually decide that within a unified group on what those might look like, but because they're so integrated that those might vary. And then that clarification comes with this caveat, and that's that the health plans might change over time their credentialing requirements for providers, and that includes pharmacists. They can do that. They typically don't do that very often, but they always reserve that right. They're ultimately in charge of who's in their network and what it takes to get into their network. And so that clarification was made in this document. So it may be that advanced certifications for all pharmacists are required, or may define different types of pharmacists based on different intensities of the services provided that might have varied requirements by that type. But typically what they do is they treat all nurse practitioners, all PAs, all pharmacists the same. When they get into physician specialists, they hold them to different standards, and that might be ultimately where we end up at some point. But based on the discussion with all the health plans that were within the stakeholder group, there are no intentions, at least in the foreseeable future, to change the credentialing requirements for pharmacists as different from those that are outlined in the policy directives document. That policy directive document relates to licensure being the minimum credentialing. Key issue, our pharmacists.
Jeff,
yeah.
One question that was asked was how often would pharmacists need to be re-credentialed? And then sanction notifications. I don't know about sanction notifications. I know One Health Port for their system, I believe, requires re-certification, so renewing of your information on every 180 days. You have to go in and verify that the information is still correct. But I don't believe that the health plans have a set limit for when that re-credentialing has to occur. But you do have to still go in and vouch that you're in good standing, and so I think that's how if you have a sanction or something against your license.
Yeah, I don't know that there's a standard, and we'll be identifying that in some of the work groups, because that's going to be, understanding recertification once you're in there, the processes. In talking with the medical association, they clearly believe that there is some undue administrative burden in the processes, and are looking for the pharmacy association's help in addressing that. So we're going to be working not only on the credentialing process and making that better expedited, but also maybe in the contracting areas and/or the billing components to make sure that they're as efficient as possible. But I don't know that I have an answer right now on what recertification. That was not part of this document, and that's something that we've identified that needs to be addressed in our work groups. So. Okay, are pharmacists required to get a diagnosis from a medical provider in order to bill a health plan for preventative care or related services? The answer is no. The key component there is required to get a diagnosis from a medical provider. Certainly, you will need to get a diagnosis in post-diagnosis care in certain situations because you have to have a diagnosis on all claim forms. But there could be a capacity with regard to preventative care or care that's not related to injury or illness, i.e. vaccination, tobacco cessation, things that are not necessarily a diagnosis but a need for therapy. That ICD-10 has diagnosis codes in the form of Z-series codes that could be used in those situations. And so that was one of the kind of concerns, is how do we empower pharmacists to participate in immunizations and other areas where they might be the one that identifies the need for therapy but aren't technically providing a diagnosis. And so there'll be more work to come in this area, but this particular document identifies that pharmacists can identify a need for therapy by way of a diagnosis code and a Z-series code for these claims. So that's the scope of what happened in those documents. What we realized, and this is actually in the documents as well, is there's a bunch of stuff that's outside this committee's scope. And we knew that there was going to be stuff. We didn't know how much. But we did know that this group was not going to be able to give us everything. And so the guidelines for internal capabilities required within the organizations to perform those interactions are not the focus of this work of this committee, and that very similar to all the other healthcare providers, pharmacists are going to have to interact with the health plans the same way others do, and contracting and credentialing and then billing components, and we're going to have to identify those on our own. This committee was not tasked to do that, and so whether it's business processes, workflow, coding, education training, clinical record management, billing, those are all components that we need to be able to provide care, submit claims, and be appropriately reimbursed for our services. We're going to be working in a number of different areas in that. So we clearly looked at our peripheral efforts, and so one is preparation of our professionals, one being the current practitioners that are out there. There's a number of knowledge gaps that we've addressed that currently are a different language for most of our pharmacists, let alone the clinical skills that may be a little rusty, that might need retooling, but also training our technicians and our student pharmacists in preparation for this brave new world that we're looking at. We also have to look at establishment and awareness of support, new processes in the areas of billing, contracting, credentialing, privileging, and then business prep. We've got a different cash flow, so where there's financial preparation and planning. We have different workflow and staffing needs, and clearly one of the big issues will be health information technology. How do we connect clinical data and then connect with medical billing systems and appropriately document so that upon audit we're able to attest that we have done that. So different from our pharmacy software, the medical billing component is unique and different, and we have to learn, as we did with pharmacy billing, how to make that work. Now in the health system settings, likely they have medical billing specialists and offices, and that might be an easier transition for them, and that we will see if there's any hiccups over the course of the next year. But as we're working in settings that don't have support staff, how do we prep for that? So knowledge gaps that we've been able to initially identify, and as we peel back this onion, we're finding more and more things that we can work on. But tailoring and transitioning care to recognition within the medical benefit coverage. So how do we show our worth within the medical benefit coverage? Why should you use a pharmacist? What can we do and provide? So what's the reason why they would include us in the provider networks? And then systematically, how do we get into those networks? So credentialing processes, whether it's delegated credentialing or within an agreement between a hospital or a clinic and a health plan, or the direct credentialing between a practitioner, pharmacist, and the health plan, which is what most people will be doing after 2017. Privileging processes within health systems, contracting with the health plans and PBMs. Obviously we've been contracting with PBMs. How does that differ from health plans? What are the nuances that network adequacy that we've discussed? A bunch of stuff in the billing processes. It's retrospective billing. We don't have an agreement by an electronic claim sent real time to say that this is covered. We're going to be providing service, retrospectively billing, and then getting a payment back or denial back, sometimes a month after or maybe more. So how does that look and work? What is the documentation components? There's a number of different nuances and skills to appropriate documentation, either based on level of service or time, and then identifying covered services, the coding issues with ICD-10, CPT codes, HCPCS, referrals, what are they going to be required, when are they not, avoidance of duplication. If you've got to see another provider and then a pharmacist sees them the same day, the pharmacist won't get paid. How do we avoid that duplication? What are the appropriatenesses in communication with other providers, and then potentially in pharmacists' process to have a patient sign off that they have not received that care, and can we do that within our contracts in our state? Patient billing, copays, coinsurance, prior auth, referrals, a bunch of components, and then audit protections, of course. And then we've got health information technology, clinical data sharing, electronic medical records, practice management software that allow for scheduling, billing, business management. So a bunch of components that we've identified as knowledge gaps. So our next steps are we're going to be working with our members to help address those knowledge gaps, and then working throughout the country really to help share information. We have alignment with Oregon and California leadership in those states, because we've had Practice Act changes in Oregon and California, and so there's a lot of work being done on the West Coast. We want to make sure that we're working together and consistent, and so that the plans recognize us in a similar fashion, and that we're not held to some obscure rule in California and or Oregon, but that our work is parallel. So in order to do that, we've recently announced that we're going to be putting together these implementation work groups, and we have 4. One on credentialing and privileging, one on billing, coding, contracts, and documentation, one on technology and communication, and the other on outcomes and research. The credentialing and privileging is going to be to avoid overlap. We really want to make sure that all 4 of these work in concert, but we're trying to identify what the scope is so that there isn't any redundancies. We're going to determine best practices and tools for credentialing and privileging of pharmacists, and the potential tasks would be building credentialing tools, comparing and contrasting credentialing requirements, looking at national guidelines if they exist, and providing guidance for how to privilege pharmacists within different settings, and then identifying gaps in education. The billing, coding, contracting, and documentation really is going to be the nuts and bolts in what ICD-10, HCPCS, CPT codes, codes are out there, any gaps in the billing codes and things, where does the Z code not fit, what areas are we going to be looking at. Looking at contracts and best practices and how to appropriately contract, looking at the complexity versus time-based billing and documentation requirements, and then looking at the documentation and coding standards for medical services and providing some guidance on that. Outcomes and research is a huge one. We want to be able to show that pharmacists are appropriately positioned within the healthcare team and and compensated for their work. And so how do we define that over time? So we really need to look forward over hill and dale and assess what metrics are currently in place, and then align research and documentation of outcomes to show the value of pharmacists. And then last but not least, and certainly a huge component, is technology and communication, really looking at the infrastructure. And that's looking at not only health information technology, but also processes, workflow, looking at the resources out there, the different vendors, what's the pros and cons, so we can help people appropriately communicate and apply technology in their processes. We'll be working on this over the next 6 months, essentially, but primarily it's going to be starting the beginning of the year. Hopefully, we'll be able to get a bunch of work done by April, and then WSPA staff will work on some of the working components with key individuals that have identified any expertise and desire to help in certain areas. And then we'll obviously be working on research outcomes ongoing as we continually assess them. So, in kind of looking at this, all this work, we have to stand back and say, we've been working on this a long time. And really, it's been a heavy lift for a lot of people over decades. And sometimes, and I thought this quote really fit from Malcolm Gladwell. It says, when you look at the world around you, it may seem like an immovable, implacable place. It is not. With the slightest push in just the right place, it can be tipped. And I think you're seeing the tipping point of how pharmacists are used. We've had a lot of work throughout states all over around the nation, led by the state of Washington years ago, and we're seeing pharmacists being integrated in many ways and being recognized by health plans for the care that we provide, and it's an exciting time for our profession. But with that, our next challenge is adapting. And so I thought this quote was poignant. And Nolan Ryan, Hall of Fame baseball player, stated that enjoying success requires the ability to adapt. Only by being open to change will you have the true opportunity to get the most of your talent. And I believe pharmacists have that talent. We just have to adapt it to a new system of requirements, and we have the opportunity to do so. So with that, I want to ask for any questions as we close up today, and ask you to contact the WSPA if you have any desire. So I thank you for your time, and would like to look at address any questions that you may have. Jenny, do we have any questions?
I'm working on unmuting everybody. I thought I did, and I'm not sure that I did. But we do have one question that was asked during the webinar that I didn't see until just after that opportunity really asked, and that's around what the legal definition of network adequacy is.
Actually, it's a really unclear component right now. There is a very thin part of our state law that is open for the interpretation of the Insurance Commissioner's Office. So we're going to be working with them to more clearly identify how they internally figure that out. But there is a definition within law that basically points to the insurance commissioner assessing adequacy to ensure that patients have access to care in their areas. And our job over the course of the year is to really get to be experts in that area, and likely to special job.
I tried to unmute everybody, but then we got too bad audio feedback there. So go ahead and we'll continue to answer questions through the question bar. Sorry about that.
Okay.
Another question we had is, are we working with the APHA?
Of course. Yeah, I've actually presented to their board of trustees and their governance committees to talk to them about the nuances of that. And I actually will be presenting twice at the upcoming annual meeting on this particular effort. They're very interested. ASHP, NCPA, all of our national partners. I even was invited to go to the Academy of Managed Care Pharmacy and spoke to them not too long ago, actually a couple months ago, and it was really well received. These are pharmacists that work in PBMs and in health plans, and they were excited about it, and they offered some suggestions on kind of internal barriers that might stand, in the way of actualizing this. But it was exciting to see such a warm response. And I have to say, from a standpoint of working with the plans through this process, they've been, specifically the Blues have been working with us very well to try to integrate pharmacists in an appropriate way. And it hasn't been obstructionary. Even throughout the legislative process, they recognized the value of pharmacists and stated that in testimony. It was more about the lift of putting this together and getting them incorporated. But the pharmacists working within the plans have stated that they are supportive of this on the inside. Even though they're overseeing the pharmacy benefit, they're working with the medical services side to help them to understand what pharmacists can do and how that could be handled.
And then I guess the audio cut out a little bit right as you were saying for some people that yes, we are still looking for volunteers for the committees. Just to clarify, if people would like to help with the committees, they can email me at Jenny, Jenny, at WSPARX, or look at the email we sent to our members. Another question for you, Jeff, is clarifying that CDTAs are still going to be required to prescribe medications, but billing and the clinic being able to bill for the clinic services is separate and not necessarily directly tied to CDTAs. CDTA may give you the ability to prescribe and practice at a higher level, but not necessarily required for the billing or linked to the billing in a specific way.
Yeah, I think that's a great clarification. It was a real big part of our discussions early on, is we didn't want the billing for a service to be only allowed by pharmacists who have collaborative drug therapy agreements, and that clarification was put into this document. A very good example would be the ordering and review of labs, which is a part of our medication use components. The components within our scope of practice, case in point, like tobacco cessation, where there's a component of over-the-counter products that don't require prescription, but the counseling and the behavior modification training should be a available moment in the payer's eyes in the near future with the ACA. We wanted to make sure that those components were recognized independent of a collaborative drug therapy agreement. Certainly, we expect that the collaborative drug therapy agreements will be utilized to increase the level of service and potentially the the level of complexity of the interventions, and then the billing would follow that.
And another one was asking about the PBM's role in this and anything the PBM might do to thwart this. And I think the clearest answer to that is this is on the medical side, and so really shouldn't have anything to do with the PBM other than, services that are linked to dispensing generally prohibit the added on billing on other services. So there will need to be a clear differentiation between prescribing or dispensing under a PBM contract and professional reimbursement there from the medical side, so there's not redundancies. I think that's definitely a concern and a valid one of the insurance carriers. Some folks, person for you, Jeff.
I'm sorry. The PBM component, to add to that, though, the plans have stated that they may require the PBMs in their contracting with them to take on some of this role. We're unsure what that might look like in the future. And so the medical services versus the pharmacy services is how it stands now, and we'll be working along this process to assess where the PBMs might be integrated in and how we need to adjust or address any changes there. Sorry.
Oh, no, the other is one person asked about the potential 15 other states that are close as well. Maybe I can have that person, if they have interest in kind of the national strategy, to contact you directly at the WSPA office.
Yeah,
and then
yeah, I'd be happy to. I don't have the 15 states on top of my head, but I know that. So I work with my national partner at NASPA, the National Alliance of State Pharmacy Associations, and they look at each state because all of us are members. And so I'll be working with them to share this information for state efforts, as well as with national partners on a federal effort. And we've been continued to work with them. They're well informed on this, and we meet fairly regularly to discuss things like this.
And another question is, do you have to be a pharmacist to participate in the work groups? No, you don't. There will be a lot of folks within institutions that have billing and credentialing expertise and technology folks that will be great additions to this, that work with pharmacists at their sites, but clearly aren't necessarily pharmacists. We are encouraging the pharmacist members within our state that are actively involved, or pharmacist work group members, to be WSPA members, so they're fully engaged in our work. But no, we are looking, actually actively trying to seek out people besides pharmacists that think differently than us to be a part of the work group. And then more questions about volunteering. Yes, we would love students to be a part of the work group. We're working on kind of a special, well, fourth years, that's, you're entering more as kind of a practitioner into this work. But even we've had some volunteers from first years, and we'll be working on how we integrate you and use your skills and knowledge and enthusiasm to help the group. And participation in the work groups will be, we'll have the opportunity for in-person, but knowing that our state is large and there's partners outside of our state who may be able to contribute to some of the work group, we will work on having a virtual interface for any meetings that we have live. And then we will be trying to do a great deal of the work, as much as we can, via email, via phone conferences, to try to facilitate people helping outside of the immediate Seattle area, outside of our office setting. Great.
And I just wanted to add one thing. I was looking through, and Amber Glass shared a statement here that I think is really important for us to bring up. And as we've been going through this, we've been learning from the delegated credentialing institutions a little bit about process and how well it's been received by their med staff offices and the physicians. And we knew that the physicians had supported it because they were supportive of our bill. But that doesn't oftentimes mean that folks within the billing department or the credentialing department don't just see this as more work for them. And so how well it's received internally, I think, is something that we're finding out. Well, this, we're going to do this in a slow rollout because we don't want to overwhelm the people that are doing the work in our institutions. I think we're going to see a lot of that moving forward. But a really good news on that front is that the Board of Regents for the UW Medical Center in Harborview just recently identified all pharmacists as medical providers, and they basically are going to be doing their credentialing of them within the physician credentialing components. That's a big step. In fact, that's the first one of all of our hospitals to do that, and I think that you'll see more to come. Clearly, UW Medicine and Harborview has been on the forefront of utilization of pharmacists. They've even credentialed their pharmacists in the past. So they're setting a nice example. Virginia Mason is clearly doing the same, and we're hearing great comments from folks as they employ that. To that end, if you have any roadblocks, concerns, questions, comments, we're here to help, whether the WSPA knows or whether we can identify some people that are in similar situations that you can work with. We want to be there for you. So it's exciting times, but in that time there may be some potholes, and we want to try to smooth that road out for you. So with that, I thank you so much for your time, and we are available at the WSPA office, and like Jenny had mentioned, please contact her for any desire to work in the work groups, and we'd love to work closely with you on this. Thank you so much, and have a wonderful afternoon.